So today in this session, after hypermetropia and myopia, we will be discussing about aphakia as well as pseudophakia. So these two are very importantly asked questions in our exams and all. So the first one we will discuss with aphakia. So when I told hypermetropia as well as myopia, we discussed that what is the importance of a lens, right? When I was telling hypermetropia, I told about the term aphakia also. So generally, aphakia means it is the absence of crystalline lens. So basically, by definition, it means that the crystalline lens is absent. So absence of crystalline lens is the main thing. Now, usually we say absence of crystalline lens is aphakia. But to be more precise, if there is an absence of crystalline lens in the pupillary area, the right place for the lens is the pupillary area. So from the pupillary area, if it's absent, then you call it by the name aphakia. That is a much more precise way of defining aphakia. So absence of crystalline lens, to be more precise, from the pupillary area. So now if there is no lens in the pupillary area, what is it going to bring to the patient? What is going to happen to the patient? Yes, patient is going to have hypermetropia. Hypermetropia is going to be there, and this is usually a high degree hypermetropia. A high grade hypermetropia is what the patient is going to end up with. So absence of crystalline lens from the pupillary area is going to cause high degree hypermetropia in the patient. Now, what else can happen? Of course, the power is going to be decreased. Normally, it is a 60 diopter, our eyes, but now from 60 diopter, the power is going to decrease to 44 diopters. So that significant decrease of power is also associated with an aphakic eye. The next thing is that the accommodative effect or the ability to accommodation is completely lost for these eyes. So accommodation is completely lost. So these are the four important points that you have to remember or write in case of a definition. So it's going to be an absence of the crystalline lens, to be more precise, from the pupillary area. It is going to result in a high degree hypermetropia in the patient, and the total power of the eyes is going to reduce from a 60 diopter to a 44 diopters. Remember the number 44 diopters. Now accommodation of the eyes, the ability to accommodate is also lost in these patients. So by definition, these are the four important points that you should write in the first segment. Now, of course, the next thing that we will discuss is coming under the heading causes. What are the common causes in case of aphakia? So aphakia, when you say that is the absence of crystalline lens, it can be like you remove it particularly, or it can be because of any other causes that has led to a complete absence of the lens. So always remember that. So obviously the first one, which was surgical removal, is there in our list. Surgical removal is there. It's the second one. The first one is the congenital absence. By birth, if the child doesn't have a lens on its own, then you call it by congenital absence of the crystalline lens. Then there can be a lens in the child already or in the patient already, but because of certain diseases or certain conditions that exist in the eye, there can be absorption of this lens matter. So a complete absorption of the lens matter occurs in some patients, and because of that, patient can become aphakic. Then there can be a traumatic extrusion. Some kind of trauma has occurred to the eye, and because of the impact of the trauma, the lens which is to be placed in the pupillary area has been displaced or completely being destroyed. So that is the fourth one, which is the traumatic extrusion. Finally, a posterior dislocation of the lens. Because of any causes, there can be a variation in the position of the lens as well. Again, hypermetropia, so it's going to be a posterior dislocation of the lens. So basically 5 causes we will be discussing. The first one is a congenital absence of the lens. Surgically, you're going to remove the lens, making the patient aphakic, absorption of the lens matter, then traumatic extrusion, as well as posterior dislocation of the lens. These are the 5 important causes of aphakia. Now, coming to the clinical features. Under the heading clinical features, we know there are symptoms and signs. Obviously, we start with symptoms. In symptoms, the first one is defective vision. Of course, the patient is not able to have a normal vision because there is no lens. Lens is very important for the normal vision. So, patient is going to have vision problems for sure. Now, which vision are we talking about? Is it a near vision or is it a far vision? Here, in patients who are aphakic, both near vision and far vision is going to get affected. So, in hypermetropia, the patient had a problem with seeing the nearby objects. That is, it was a long-sightedness. But in myopia, the patient had a problem in seeing far away objects. But in aphakia, the patient is going to have problems seeing both far away objects as well as nearby objects. So, both near vision and far vision is going to be affected. Now, why is it like that? This is because of two reasons. Now, let us go back to the definition. In the definition, the second point as well as the last point. So, the patient is going to have a high degree hypermetropia as well as loss of accommodation. So, high degree hypermetropia. Hypermetropia means it is long-sightedness. Patient will be able to see long or far away objects properly. So, here the patient is having a problem with the near vision. Near vision, patient is not able to see, right? Long-sightedness, only far away objects patient is able to see. Now, that is why the patient has a problem with near vision. Now, what about far vision? Far vision is because the patient is not able to accommodate the eyes. So, because of these two reasons, the patient can have problems with both far as well as near vision. Now, coming to the next one, which is erythropsia and synopsia. So, if you see here, I have labeled or marked or underlined it with red color as well as blue color. Erythropsia is red and synopsia is blue. Basically, this is because, now what is erythropsia and what is synopsia? Erythropsia is seeing red images and synopsia is seeing blue images in the eyes. Now, this is commonly mentioned as symptoms from the patient. Now, why does this occur? What is the reason? Because of the absence of the lens in the pupillary area, there is increased presence or entry of ultraviolet rays as well as infrared rays into the eyes. So, when more rays, more infrared as well as ultraviolet rays are being entering into the eyes, patient can see these blue as well as red color images. So, UV rays is related to erythropsia and infrared rays is related to synopsia. So, it is correlated. So, because of the more amount of entry of these rays into the eyes, patient can feel seeing blue color as well as red colored images. So, that is called by the name erythropsia and synopsia. So, defective vision, near vision and far vision is going to get affected. Erythropsia and synopsia is there. These are the common symptoms that the patient is going to complain. Now, coming to the signs. What are the common signs? So, signs is pretty easy to discuss here. To start with, obviously the first and most common one in case of aphakia is a surgically removed lens, right? Surgically, the patient has undergone some surgery, because of that the lens is being removed. So, most of the times when it is a surgically induced aphakia, there will be a scar where we have done the surgery. A scar will be seen in the cornea. So, a corneal or limbal scar is very much essential to be seen in case of signs. So, look for a scar in the cornea or the limbal area. Then you can see that the anterior chamber, it is similar to hypermetropia. Always remember the signs of hypermetropia to correlate with aphakia. So, here also the anterior chamber is going to be little deeper compared to that of the normal. So, a deep anterior chamber is our second point. Then comes iridodonosis. Now, what is iridodonosis? Iridodonosis is tremors of the iris muscle. The iris muscles are going for excessive tremors. So, that is called by the name iridodonosis. So, that is also one important finding that you can see in case of aphakia. Then comes jet black pupil. So, the color of the pupil is very black. A jet black pupil is a common appearance in case of aphakia. Then you can go for a Purkinje image test. So, normally in a Purkinje image test, you can see 4 images. But here in case of aphakia, what you can see is 2 images. 2 images will be seen out of 4. Normally, it is 4 images that you can see in case of Purkinje image test. But here, because of the hypermetropia as well as aphakia, there are only 2 images seen. So, 2 out of 4 is our point. So, that is about Purkinje image test. Then comes the fundus examination. So, in fundus examination, obviously in hypermetropia, we saw a very small disc which showed features of pseudopapillitis and all. So, here also we are going to see a small disc, a small hypermetropic disc. So, fundus examination is going to show a small disc. Finally, you can do retinoscopy, autorefractometry, and in that you can see that there is high degree of hypermetropia in the patient. So, that is the important clinical findings. So, we will just recollect about the symptoms as well as the signs. Symptoms very easy: defective vision, near vision and far vision both is going to be affected. Erythropsia and synopsia is another important 2 findings or 2 important features that the patient usually complains of. Now coming to the signs, starting with the corneal scar or a limbal scar, you can look into the anterior chamber which is usually deeper compared to the normal range, as well as iridodonesis, that is a tremors of the iris muscle is usually seen. A jet black pupil is our next point. A Purkinje image test showing 2 images out of 4 images. Normal is 4. In case of aphakia, we can only see 2 images. And finally, a fundus examination which is going to show a small optic disc, which is usually a finding similar to hypermetropia. And finally, in retinoscopy and autorefractometry, you can see that there is a high degree hypermetropic eye. So, these are the common signs that you can see. Now, we discussed about the definition, what are the common findings, how it occurs, the etiology, then the signs and symptoms. Now, the last one is treatment. How do you approach a patient or how do you treat this patient? Now, treatment, as similar to hypermetropia and myopia, we have an optical correction as well as a surgical correction. So, an optical correction is mainly done by a convex lens similar to hypermetropia. So, you start optical correction with a convex lens, and this convex lens can be advised as spectacles, contact lenses or intraocular lens. You can give us a spectacles, a contact lens or an intraocular lens placement insertion. So, when you place this intraocular lens inside, now it can be of 2 different types. This can be a primary intraocular lens or a secondary intraocular lens. A primary intraocular lens is usually done at the time of a cataract surgery. So, when a patient has cataract, you remove the normal normal lens, and then hence the patient has aphakia, and then you put a new lens, a corrected lens inside, then that kind of intraocular lens implantation done for aphakia is called by the name primary. Now, what about secondary? Secondary is called when a patient who already is aphakic is going for a placement of intraocular lens. So, not related to cataract is called by the name secondary. If it is related to cataract and during cataract surgery, you are going to put a new lens to correct the aphakia, then you call it by the name primary. So, convex lens is ideally given, spectacles, contact lenses or intraocular lens implantation. Now, what are the surgical methods? Again, intraocular lens implantation comes under surgical methods, but then the proper surgical method for a correction of aphakia is a refractive corneal surgery. So, you have to correct the refractive error. You are going to correct the refractive error by doing a surgery in the cornea of the patient. So, here when you do it in the cornea, you call it by the name of refractive corneal surgery. Most of the time it is LASIK, laser assisted in situ keratomiliasis. So, that is what is about aphakia. Starting from definition, we had 4 points, then causes, 5 causes we listed, clinical features with symptoms and the common signs, iridodonesis, jet black pupil, Purkinje image test to be remembered, and finally the treatment with convex lens as well as refractive corneal surgery, which is LASIK. So, this is about aphakia. So, aphakia in a nutshell would be only this much. So, in the next session, we will discuss about pseudophakia. So, after aphakia, our next topic for discussion is pseudophakia. So in pseudophakia, again the word itself is going to tell you what is it actually. So pseudophakia. So there is a lens here, but it's not a true lens, not the true crystalline lens of our eyes. So aphakia, when it is corrected with an intraocular lens, that is what we are discussing here. So there is an aphakia in a patient, but you have corrected it with an intraocular lens. There is a new lens inside, but it's not the original crystalline lens of the human eye. So when a new lens is inserted, you call it by the name pseudophakia. Now, what are we interested about pseudophakia? Yeah, pseudophakia is going to be of 3 different types. How? Because, or why? Because, see, when you put a new lens inside the eyes instead of the normal crystalline lens, it can be of the same power of the normal eyes, or it can be of increased power or decreased power. There can be a wrong power also. So based on that, the patient can have different refractive status of the eyes, which the first one being emmetropia. So the first one is an emmetropia. So in the starting of our discussion session, I already mentioned what is emmetropia. So emmetropia is the perfect refractive status of the eye. So here what happens is the power of the IOL which is inserted or which is implanted inside is exact. It is the correct power of the human lens, human crystalline lens. So here what happens is the patient usually requires a glass for near vision. Otherwise, no other issues the patient will have. The normal eye power is maintained there. It is the correct or the most ideal state in case of pseudophakia. But there can be an overpowered IOL or an underpowered IOL being inserted into the patient. In that case, patient can develop 2 important conditions. The first one being a consecutive myopia and the second one being a consecutive hypermetropia. So obviously, if it is an overpowered intraocular lens, if the power of the intraocular lens which is implanted inside is more than that of the desired power, then you end up having, or the patient will end up having, a consecutive myopia. Suppose if it is an underpowered IOL which is being inserted, then it becomes a hypermetropia. So remember, when we studied about the hypermetropia as well as the myopia findings, if it was all small in hypermetropia, right, and it was all large in case of myopia. So here also it is a small intraocular lens, a underpowered intraocular lens causing consecutive hypermetropia and an overpowered intraocular lens causing consecutive myopia. That is how we can remember things. Now, in case of emmetropia, I told you the patient will require only glasses for a near vision. Now, in case of hypermetropia, consecutive hypermetropia or consecutive myopia, what does the patient require? So, in consecutive myopia, the patient will require a glass for distant vision. The distant vision is going to be in trouble. So, a glass should be given to satisfy or to fulfill the patient's needs for distant vision, right? That is about consecutive myopia. Now, what about hypermetropia? In case of hypermetropia, the patient requires a glass, sorry for the spelling mistake. So, it requires a glass for both distant as well as the near vision. So, you require glasses for both near vision as well as the distant vision in case of hypermetropia, and you require glasses for distant vision in case of consecutive myopia. So, that is how the types and basically the treatment required for each is classified. Now, let us see what are the common signs. When a patient comes who is having already a pseudophakic patient comes with a lens in situ, you will examine if he or she is having a refractive errors, we will examine the patient, right. So, when we examine the patient, what kind of features can we see in this case? So, obviously, we will start with a surgical scar because pseudophakia and a new lens is implanted, there is for sure a surgical scar there. So, a surgical scar will be seen in the corneal or the limbal area. Then the anterior chamber, which is usually slightly deeper compared to the normal value, and then mild iridodonosis. Iridodonosis was there in case of aphakia. Here mild iridodonosis can be seen. Then the Purkinje image test comes, but here the Purkinje image test is going to show all the 4 images. It's unlike the aphakia where we can only see 2 images. Here we can see all the 4 images. So the score is 4 by 4. All the 4 images can be seen here. Again, the pupil is black in color most of the times, but when light is shown, you can see small shining reflexes in the pupillary area. Okay, and after complete dilatation of the pupils, when you examine under the slit lamp examination, you can see that there is an intraocular lens which is present inside. So when you completely dilate the pupil and you examine under the slit lamp examination, an intraocular lens is confirmed within the eyes. Then the visual status as well as the refraction based power of the IOL all should be determined as such. So this is about the signs. So starting with the surgical scar, a slightly deeper anterior chamber compared to the normal, a mild iridodonosis which can be seen sometimes, a Purkinje image test showing 4 images out of all the 4 images, a black colored pupil. In aphakia it was a jet black pupil, but here it's going to be a black pupil, and sometimes when you show the show light to the eyes, to the pupils, you can see that there is a shining reflex in that area. And a slit lamp examination after complete dilatation is going to confirm the presence of an intraocular lens within the eyes. So these are the common signs that you can elicit out in case of pseudophakia. Now coming to the management, how do you manage? We already discussed, we know there are 3 types of pseudophakia, starting with emetropia, consecutive myopia and consecutive hypermetropia. So emetropia, we know everything is fine, it is the ideal situation. Patient will require spectacles only for, or the glasses only for what? Near vision. So here spectacles is the first thing where you can give treatment. Management starting with spectacles for near vision alone. Mainly it is seen in emetropic condition, emetropia. So that is where you see it. Now there can be lenses which are bifocal. That means a lens will have, in the upper segment it will be concave and in the lower segment it will be convex. So they can be bifocal or progressive glasses can be given, which will satisfy both the distant vision as well as the near vision of the patient. So that is a second modality of treatment. Then coming to the surgical management, you can go for LASIK or advanced surface ablation, mainly in a moderate error. If there is a consecutive error, consecutive refractive error, and if it's a moderate kind of error, you can go for this kind of procedures like advanced surface ablation or a LASIK. And finally, if it is a very high grade refractive error with the new lens, if the new lens which is implanted, then you have to go for complete lens removal and putting a new lens instead. So that is what is called by the name intraocular lens exchange. So intraocular lens exchange means the patient is having a lens of the wrong power. You want to take that lens outside and you want to give a better lens of the right power to the patient. So that is what is called by the name intraocular lens exchange. So treatment modality starts with spectacles for near vision in case of an emetropic pseudophakia and bifocal or progressive lenses, which is going to satisfy the need of both distant vision and the near vision in case of a patient with consecutive myopia or consecutive hypermetropia, mainly consecutive hypermetropia. Then LASIK or advanced surface ablation if it is a moderate kind of error. Otherwise, you go for, especially if it's a high grade, you go for intraocular lens exchange. Very small topic, very simple topic, just a few things you have to remember. So pseudophakia is also a frequently asked question. The signs is very important. Slit lamp examination, IOL confirmation, then Purkinje image showing 4 out of 4, surgical scar, then the types emetropic, consecutive myopia, consecutive hypermetropia. These are the important things that you should remember in pseudophakia. So the refractive errors as such starts with hypermetropia, myopia, aphakia and pseudophakia. We discussed all the 4. The next thing or the next session is about the accommodation, the ability of the eyes to accommodate. What happens if accommodation is not happening, and if at all there is some problems with the accommodation, then what are the manifestations that the patient can have. So that will be in the second session. So in the section of optics, we have discussed so far about all these topics. The last but not the least important one is about accommodation. Now let us see what is accommodation. To understand accommodation, you should know what in an emmetropic eye happens, what happens in an emmetropic eye. So normally, we all know whenever parallel rays of light is coming from infinity. So any parallel rays of light coming from infinity is always brought to a point in the retina. That point is called by the name focus. So parallel rays of light which is being coming from the infinity is always brought to a focus point in the retina, right? There is a focus point that is being merged. All the parallel rays are being merged at that one point. Now, this happens when accommodation power of the eye is at rest. That is, accommodation is not working at all. It is at rest. That is the thing that happens here. Now, imagine there is an object in front of your eyes. That is an object in the near like almost at the near proximity of the patient's eye. So what happens? There will be certain parallel rays coming from a near object, but they are usually diverging rays. After each refractive index being transmitted and the rays coming inside the eye, they have a tendency to get diverged because the distance is reduced. So these diverging rays, which are usually coming from a nearby object, will also be focused at the retina. So normally it will not be happening, but in our eyes we have a mechanism so that this diverging rays coming from a nearby object is made to focus on the retina. So the diverging rays are also focused on the retina. Now how is this done? How is this diverging rays being focused on the retina? Now this is done mainly by increasing the curvature of the lens. So the lens curvature will be increased, and when the curvature of the lens is increased, obviously the power of the lens is also going to be increased. So more the power, that is how accommodation is done. So basically when power is more, all these rays will be able to be converged at a point in the retina. So remember, parallel rays of light coming from infinity will be focused at a point on the retina when accommodation is at rest. That is normal. Again, in a normal eye, if there are parallel rays coming from a nearby object, these rays usually have a tendency to get diverged. But these diverging rays are also made to focus on a point in the retina. Now, how is this possible? This is possible because we have the mechanism of accommodation. Now, in the mechanism of accommodation, what happens? The curvature, the lens curvature is going to be increased. So when the curvature of lens is increased, the refractive power of the lens is increasing. Thus, the point, all the diverging rays are made to focus on a point on the retina. Now, when you consider the lens, there is an anterior area as well as the posterior area, the anterior surface as well as the posterior surface. Usually, in a normal lens, the anterior surface is the diameter of the anterior surface is more than that of the posterior surface. So here when you compare the anterior surface as well as the posterior surface, whenever accommodation is being on action, the posterior surface curvature remains the same. There is no increase or decrease in the change or in the size of the posterior curvature. But in the anterior surface, there is a significant decrease. That is how the curvature of the lens is increased as well as the power of the lens is increased. So remember that this is what is happening in accommodation. Now, how is this curvature is being increased? Let us see that in the heading mechanism. Now, when you see the mechanism, first we will see how is it remaining at rest. So, at rest, that means when it is unaccommodated, there is no accommodation happening. At this time, what happens is that the ciliary ring which is there is large, and the zonules which is connecting is very much tensed. So, it is actually pulling the lens apart so fast. So far, the zonules on the either side is tensed so much that it is pulling the lens on the either sides. So, what happens? The lens becomes a flat lens. So, there is a flat lens on the appearance in case of unaccommodation. So, the ciliary muscles, the ciliary ring is large there, and the zonules which is attached on the either sides, they are pulling it so hard. They are tensed and they are pulling the lens particles so hard. So, the lens has become a flat lens. The curvature is very much less. But in accommodation, the ciliary muscle contracts. So, the ciliary muscle contraction occurs first. So, when the ciliary muscle contracts, the ciliary ring shortens. The ciliary ring is now shortening because of the contraction. So, that is the first thing that happens. There is shortening of the ciliary ring. Now, when that ciliary muscle contracts, the zonules are released. The tension of the zonules is down now. So, zonular tension is released. So, what happens? So far the lens was being stretched. Now the zonular tension is released and the lens has become relaxed. So the deformation of the lens substance occurs. So that is how in accommodation the curvature increases. So when it is being stretched, the curvature is less, the lens is a flat one. So when that stress on the either side, the tension on the either side is released, it becomes like a dome shape. So a particular type of lens which is having increased curvature is there. That is how the mechanism is acting. Mainly it is the ciliary ring, the ciliary muscle contraction and relaxation that depends here. When the ciliary muscle contracts, the zonule tensions are released, and so far it was holding the lens apart, making it very thin lens so far because of the zonular tension. But once the ciliary muscle contracts, the zonular tension is released and now there is a curvature, increased curvature of the lens that occurs. Now here always remember the point, the near point as well as the far point in this area, because this will help you in understanding what is presbyopia. So near point is the nearest point at which any small object which is placed in front of you can be seen clearly. So when an object is placed in front of you, the nearest point at which that object should be placed so that that object is clearly visible. So that is called by the name near point or punctum proximum. Now what will be the farthest point or the distant point? So the farthest point at which any small object can be seen clearly in front of you, that is called by the name far point or punctum remotum. So normally the distant point or the farthest point is always infinity, but near point is different. It depends upon the age of the person. So now let us see how that is differing. So here we discussed about what accommodation is. Basically there is a increase in the curvature of the lens as well as the power of the lens, making it able to focus all the diverging rays coming from a nearby object. So mechanism at rest, the ciliary ring is large and the zonules are tensed, causing the lens to be flat. When the zonular tension is released because of the ciliary muscle contraction, there is deformation of the lens, making the curvature of the lens increased. So near point and far point is also discussed. Now let us see what is presbyopia. So if you have an idea about what accommodation is, presbyopia becomes easy. Now presbyopia is a physiological condition where there is an insufficiency of accommodation. So we require accommodation so that even an object placed in the front of you is also being able to seen by us. So now when age approximates, when a patient gets aged, the ability of this accommodation decreases. And because of the insufficiency of accommodation, the patient will have difficulties in seeing a nearby object. That is, basically they will not be able to focus the diverging rays at the point in retina. So it is the physiological insufficiency of accommodation. Now what happens because of this insufficiency? There will be a fall in the near vision, right? We are able to see an object in the nearest area because of accommodation. So if accommodation is not there, the near vision is going to be disturbed. So progressive fall in the near vision occurs because of the physiological insufficiency of accommodation. Now coming to the pathophysiology, let us see what happens in this presbyopia condition. We all know the far point is infinity. So that is understood. Now near point, I already told you, it varies with age. At 10 years, it's usually 7 centimeters. At 40 years of age, like 10 to 40 years of age, it is usually 25 centimeters, and 45 and above, it is usually 33 centimeters. So that is an approximate value of the near point according to the age. So 10 years, it is 7 centimeters, 40 years, 25 centimeters, and 45 years, it's 33 centimeters. Now, there is a value called by the name amplitude of accommodation. So what is amplitude of accommodation? So amplitude of accommodation is calculated by the formula, which is 100 divided by the near point minus 1 divided by the far point. So now this equation we have to substitute the values of near point and far point. So far point is usually infinity and near point based upon the age you have to take. So based on that you have to calculate the amplitude. So when age proceeds, when age of the patient is getting more and more, this amplitude of accommodation value has a significant decrease. So when there is a significant decrease in the amplitude of accommodation, there is fall in the near vision. That is, near vision starts failing. So decrease in the near vision. So that is what is happening here. Now, what are the causes of this? So that is understood. The first one is what presbyopia is, the pathophysiology, the amplitude of the accommodation is being decreased. Now, I am always telling amplitude of accommodation, amplitude of accommodation. To understand this, you should know what is the causes. We already know why there is a decrease in the accommodation. Why there is accommodation? Because it is the power of our eyes to make all the diverging rays focus in the retina. So if this is not happening, we will have a problem with the near vision. Now, we already know why or how this lens is being, like the curvature of the lens is increasing and decreasing based on accommodation. The principle we know, the mechanism we know. Now that mechanism is going to get failed here. Now what are the conditions that will lead to the failure of this mechanism? That will be the causes here. So in the causes, the first thing is the capsule is actually a very elastic thing in the lens. So that elastic nature of the lens capsule is making the increase as well as the decrease in the lens curvature. So here when the age approximates, the lens capsule becomes less elastic. The changes in the lens capsule is the first thing according to age. Then there can be increase in the size as well as hardness of the lens. Basically it is called by the name sclerosis. Then age related decrease in the power of ciliary muscle. The ciliary muscle also should adequately contract so that the lens curvature is increased. So here if the ciliary muscle power is reducing, the contraction of the lens also decreases based on that. So main thing, always remember the mechanism. So the first thing that should happen is the contraction of the ciliary muscle. So if the ciliary muscle power is not adequate, then there will be a problem with the near vision. That is age related changes or decline in the ciliary muscle power. So after that the next thing is the lens itself being increasing and decreasing the curvature. So this is basically upon the good health of the lens. That is the capsule should be in good health, the size should be good, the hardness should not be very severe, it should be a soft thing, the lens. So if any changes in these areas occurs also, there will be a problem with accommodation, that is presbyopia occurs. So lens capsule, age related changes in the lens capsule as well as progressive increase in the size and the hardness of the lens, that is sclerosis. Now usually this is an aged condition, that this disease occurs in after a particular age. Now can we have it before only? That is a premature presbyopia. So a premature presbyopia is also there in certain conditions. Now usually this happens whenever hypermetropia is uncorrected. So when a hypermetropic eye is present and it's uncorrected, there can be causage of these problems like presbyopia in future, because initially they will try to accommodate, but after a period of time there will be failure of accommodation. Now premature sclerosis of the crystalline lens, again the same thing I was telling, age related sclerosis is there. But if the sclerosis of lens occurs even before, that is prematurely it occurs, that is also one important reason of presbyopia. The next thing is general debility causing presenile weakness of the ciliary muscle. So again ciliary muscle presenile, even before the age has reached, old age has reached, there is weakness of the ciliary muscle. That is any other general illness existing in the patient causing a weakness in the ciliary muscle. Then chronic simple glaucoma. So these are the conditions where you can see presbyopia. So age related changes in the lens capsule, size and hardness of the lens being increased, that is sclerosis, as well as the ciliary muscle tone being decreased because of age. Premature presbyopia in uncorrected hypermetropia, premature sclerosis of the crystalline lens, and presenile weakness of the ciliary muscle, and finally chronic simple glaucoma. So these are the causes of presbyopia. Now coming to the clinical features. So in clinical features, the first thing is, where is the problem here actually? The problem is in the near vision. So, difficulty in near vision, that is the main issue. Distant vision will be most of the times fine. Initially, because of the excessive accommodation. So, whenever there is a problem with the near vision, the patient is not able to see properly through the near vision, there will be increase in the efforts of accommodation. So, initial asthenopic symptoms can be there in these patients also, like watering, spasm, causing pain, ocular discomfort, all those things will be there. So, asthenopic symptoms are also there initially, but later it will give up. Another important thing is they will have diplopia, and it's usually intermittent diplopia. This is because there is a issue with the convergence as well as the accommodation being in play together. So, it requires good coordination, both accommodation as well as the convergence. So, if this is not in coordination, then there can be problems like intermittent diplopia. So, in clinical features, difficulty in the near vision, asthenopic symptoms as well as intermittent diplopia is what we have to know. So, that was the clinical features of presbyopia. Now, let us see how to approach a patient with presbyopia, the treatment part. So, treatment part again, optics, anything, the first thing is always optical treatment, trying an optical treatment, otherwise you can go for surgical management. So, optical treatment here, convex glasses is what we prescribe. So, convex glasses for near work, that is the main thing that you have to give here for the patient. Now, when you prescribe convex glasses for the near work of the patient, always keep some points in your mind. That is, always see any refractive error is present for the distant vision of the patient also. It's not only about the near vision. Check if there is distant vision problems. If there is refractive errors with the distant vision of the patient, then that should also be corrected. So, find out the refractive error for any distant vision as well as correct it. The next thing is, presbyopic correction should be done for each eye. If there are different, like there are problems with two eyes, that each eye should be corrected separately. So, presbyopic correction in each eye should be done accordingly. Now, do not randomly fix a near point just like that. Always consider the occupation of the patient, because if you consider the symptoms of the patient, they always say complaints with the near work. So, if a patient has an occupation where his near work is at more use for his occupation, for example, a tailor who has to thread his needle, or a person who is working in watch correction or servicing of the watches and all, who has to do a lot of near work, they have a lot of exertion on their near work, like near vision. So, what happens in these patients is that if you do not consider the occupation, then that becomes an utter waste. So, here the near point correction should also always be fixed according to the profession of the patient. So, that is very important. Another thing is, do not overcorrect. Overcorrection should be avoided. So, basically convex glasses is the main thing that you can give for optical treatment for the near vision. But always make sure that the distant vision is normal. If there is any refractive errors with the distant vision, that correction should also be done. Presbyopic correction should be done for each eye, and this should be done based on the profession of the patient, as well as overcorrection should be avoided. So, that is about the optical treatment. Now, in surgical treatment, you have three important aspects. You can do procedures in the cornea, you can do procedures in the lens, you can do procedures in the sclera. So, wherever you correct it, based on which area is correction, the procedures differs. So, the first thing is cornea based procedure. So, if you make certain changes or certain procedures are done in the cornea, presbyopia can be corrected. Now, how is it done? The first one is a monovision conductive keratoplasty. So, monovision conductive keratoplasty means there is, what happens here, what we are doing here is that we do certain corneal corrections, so that one eye, in a single eye, the correction for near vision is done. It is similar to that of hypermetropia. So, correction is done in one single eye. So, monovision conductive keratoplasty. Now, monovision LASIK is there. Now, monovision LASIK, we correct one eye for the distant vision and one eye for the near vision. So, we do both sides here. So, one eye is corrected for the distant vision as well as one eye is corrected for the near vision. So, that is about monovision LASIK. Then we have presbyopic bifocal LASIK. So, a presbyopic bifocal LASIK, what we do here is we create two different concentric zones, vision zones in the cornea. So here each zone will be responsible. One zone will be responsible for the distant vision and one zone will be responsible for the near vision. So we are actually creating two different concentric zones, visual zones for both distant vision as well as near vision, one for each. So that is about presbyopic bifocal LASIK. Now we have presbyopic multifocal LASIK. So the same thing, but here in multiple steps with the help of laser therapy, you are creating multiple focal areas, multiple focal vision zones, so that the correction will be done for distant as well as the near vision. Now the next one is presbyomed laser blended vision. So in presbyomed laser blended vision, we do the same principle of a monovision LASIK, which we already discussed, which is this one, monovision LASIK. Here, along with that, we use the lasers to create a spherical aberration in the center of the lens. So we create, center of the cornea. So a laser therapy is used to create a spherical aberration. So presbyomed laser blended vision mainly is a combination of monovision LASIK therapy plus a laser technique used to create a spherical aberration. So that is about presbyomed laser blended vision. The next one is placing corneal inlays for presbyopia. Here what we do is we create small pockets in the cornea and we put corneal inlays. Corneal inlays are nothing but implants. You put small implants in these corneal pockets which is created using a laser. So that is basically cornea based procedures. Monovision conductive keratoplasty, monovision LASIK, presbyopic bifocal LASIK and presbyopic multifocal LASIK, presbyomed laser blended vision as well as corneal inlays for presbyopia. Now let us see what is done in the lens. In lens we have certain procedures. Lens based procedures, basically there are two: multifocal or accommodating intraocular lens, monovision with intraocular lens. So multifocal or accommodating intraocular lens generally means what you do there is you have to extract the lens. Whatever lens is there in the patient is being extracted. That is done. Second to that, you place an intraocular lens which is adjusting to the power of the patient. So that is multifocal or accommodating IOL. So a new IOL is put which is accommodating for the patient. The next one is monovision with intraocular lens. In one eye, you do correction for distant vision, and in the next eye, you take out the lens extraction is done and a new intraocular lens is put for near vision. So you have two eyes. In one eye, you are correcting the patient's distant vision, and the other eye, you take out the lens as well as put a new intraocular lens which is accommodating. So that is about lens based procedures. Now sclera based procedures are under trial. You have anterior ciliary sclerotomy, scleral spacing and scleral aberration, scleral expansion, keeping certain substances in between and expanding the sclera. These are all procedures which are under trial. So we were discussing about accommodation. We started with what accommodation is, what is the basic mechanism that happens there at rest and ciliary muscle contraction leading to changes in the curvature of the lens as well as the power of the lens. Then we started discussion about presbyopia, the pathophysiology, the major causes as well as premature presbyopia. Age related as well as premature presbyopia we discussed. Then the clinical features as such, and finally treatment, optical treatment and surgical treatment, surgical cornea based procedures, lens based procedures and sclera based procedures. So that marks an end to the discussion of the unit optics. So I hope you have got a brief idea about the most important topics in optics. It is important to know about hypermetropia, myopia as well as presbyopia here. That is the very most importantly asked questions. So accommodation also is important, know what is basically happening there. So that is about optics.